Good evening, everybody. Welcome. And I'd like to thank Rash for organizing this event and also to benefit from the technology for the streaming. So we organized a film and a debate, which is entitled Acting to Fight Exclusion, which was directed by Ben-Marc Fink. And we're going to meet Louise, who's in charge of the coordination and the leadership of MSF Belgium in the Congo, in Kinshasa. And Louise is sort of the red thread of this film. And you can see the work that she does. She does an admirable amount of work and works with peers, educators, members of associations, and disabled people, and to be able to communicate with members of their group. After the film, we're going to give the floor successively for 10 minutes to three people. Patrick Vastel, who is the coordinator of the TIC project at MSF for the disabled. Guillaume Le Gallet, who's the director of the association initiatives for the visually disabled. And also Gregory Keane, who is a psychiatrist and in charge as the reference person at MSF for mental health. First of all, he is a director, as I said. Ben-Marc Fink has worked for MSF for 25 years now. He began as a volunteer, and then he worked for the UEP, which is the film company at MSF, and he works very closely with the communications department now at MSF. And he is a part of this category of which is represented at MSF, who is a faithful co-worker. He's done a lot of work for MSF, but he also continues to make other films elsewhere, documentaries and films for other organizations outside of MSF, which are shown on various channels in France. And as such, MSF and other work, Benoit is a preferred spectator for MSF, and I'll give him the floor, and he'll be able to tell us why he decided to make this film and how did he go about it. So thank you, first of all, for organizing this meeting, which I'm impressed by all the means that have been put at our disposal. It's more than 20 years that I've been working with MSF, that I've done films for them, and most recently a collection of films which I've directed, were about 50 years of the association. For me, it's the occasion to reflect on the history of the organization and to think about, over these 50 years, how the association has built itself, both in its know-how and on its values and its positioning and its choice of projects. And I've also seen in this construction process, this is my analysis in any case, but there were perhaps several layers of construction. There was a first period we worked like cowboys, and then there was a wave of thinking about how we can act in a more responsible and a more respectful and more ethical way, where we ask the questions, political questions, policy questions about human resources in relation to our staff members, also questions about the economic and the positioning, and how we cannot destabilize a country when we arrive in it. And that has impacted the effectiveness, but it enabled us to be more responsible. And also this challenge, our modus operandi. I think it's perhaps during the second wave of our questioning, I don't think it's just a whole series of waves, but it was also just as important, the second wave of reflection, thinking about how we deal with ecology, how do we remain humanitarians while still respecting the environment as much as we can. So the societal themes and the impact that the notion of MSF and also to redefine the modus operandi by trying to be as effective as possible in the short term, but also to have a fairer activity in the longer term. And one of the themes of the inclusion of people, disabled people, is one of the themes I think, in my mind, should be present. I'm talking about the inclusion of people who live with disabilities. I'm not talking about the MSF staff, because that's a real topic in its own right. And I said to myself that this could be a topic as like a questionnaire. How does MSF position itself in relation to that? I perhaps was more sensitive to this topic because of my collaboration with Ali Ama and the film that you're going to see in this collection of field documentaries. I've been working on it for 7 years, but it's existed for 25 years now, if I'm not mistaken. So it exists. It's a collection of documentaries which is directed to the hard of hearing community and the various avenues we take to be able to do that, and also what are the entry points for MSF in the field. So that's the idea that motivated me. So we identified Patrice Fastel, who's part of the people, as we said earlier, because you know him. Perhaps you're going to see his enthusiasm and his ability to convince everybody to follow him in this project, which is something I really admire, because I think he has a real communicating energy. And also, he's contributed to this film, and he has raised the awareness for the protocols. A lot of people, and I find this really exciting. But the moment that who, in real terms, enacts these our policies, and I was wondering what field I could go into to be able to do this film, and there. I didn't come up very much, and the film might have been blocked there. But another person into it, Louise entered the picture at this time. You're going to see her in the film. And also the incredible energy that she's able to do, and she's able to communicate to people and to be able to carry out her project. So as a result, the film exists because of her presence. And so I'm going to go into a bit of a parenthesis for explain for the people who are not aware of MSX activities. I mean, how do we set up this project? I think the way of the modus operandi with MSF, everybody's pretty much familiar with it, but you have offices and operational centers in the 5 capitals in Europe and 1 in Africa. And in these offices, you have operations, you have desks, and we decide on the activities in response to emergencies wherever they may be. And besides that, in the field, you also have an associative life, because MSF is an association that is a non-profit charity. Within this associative movement, locally, Louise is also the leader of the association. And she asked what I could do locally to be able to be more inclusive and to turn more to the people who need our help. And that's where she initiated in Kinshasa this project. It's not a project that came as a policy decision from the operations. It's something which was born in the field by her own energy, which we were able to fund. It's an initiative which was funded in part by Louise. And I think as being a part of the debate, how are things going to change? And so she carried this project. During the COVID outbreak, did everybody have access in the hard of hearing community? And so she set up the project with a succession of other projects, encouraged her to widen to family planning and HIV/AIDS, and also to integrate that into the program. And perhaps they hadn't reached certain communities. And so it's a project which can be more inclusive and not leave people behind, and include in projects which exist already, but for whom they have no access. So for me, I realized that the film, and the best part of the film, and the most interesting part of the film, is not the film so much in itself but it's what comes afterwards. It's about the debates, and it's very good to have this debate after the film, and we're going to question ourselves and questioning about our practices. But I think above all of the discussion we'll have after the film, which I think should be the most interesting. So I think it's time to watch the film, and we will come back in 26 minutes to open up the discussion with the three presentations. Well, so there you are. So this is the film. It's a project which demonstrates that things are possible. And now we're going to move on to the discussion period. By definition, there are probably going to be a myriad of questions. And yet, to start off with the question, to give us an orientation for the debate, how can we improve access to care and aid for people living with a disability in a humanitarian situation? And so this evening, we have three actors. There's Patrice, Guillaume, and Grégory going to help us answer these questions. So I'll now give the floor to Patrick at first. So Patrick is the coordinator of the International Project for Inclusion of People Living with a Disability at MSF. He's the author of the motion, which we talked about in the film in 2016 about including people at MSF with a disability. And moreover, he has worked for some 20 years in various missions for MSF, and also the Norwegian headquarters of MSF, where he was the general director for between 2003 and 2011. Patrice is a member of the Norwegian Association of the Hard of Hearing. And so I will now give the floor to Patrice. Thank you very much, Elba. Just to make sure that you can hear me properly, this is a great moment in my mind. And I'm very pleased to have seen this film. It seems that it's an extraordinary pleasure. So I'd like to give a big thank you and my support to Louise and the team in Kinshasa, who is working. Also a major thank you to Benoit and his film, and also the criticism that I think that we have to embrace, and also the crash to have the chance to do this debate. First of all, I think that this film is welcome to strengthen in our present efforts to encourage our community approach, and for the working with the associations of people living with a disability, and to provide a quality service and not to leave people behind, as above all people who were living with a disability. To give you a general picture, the people living with a handicap represent 15% of the world's population, according to the WHO, and this percentage is practiced probably even higher in places where MSF works. And disabled persons are particularly victims of sexual violence. And people living with a disability have a bigger need for having access to health care in areas where we work. People living with a disability are living in particularly difficult situations in many areas where MSF works. And there's a strong link between poverty and their disability. So as a humanitarian organization, it is our duty to question us in each project, and also to ask the question in practical terms: why are patients not arriving in our services? Who are those most vulnerable? And we know from the experience of several players that people living with a disability are often faced by many barriers to be able to access services, especially health care in particular. And so where do we stand at MSF and in the movement in general about including people living with a disability? As was mentioned in 2016, we voted a motion for including people living with a disability. And since 2018, we opened up a specific international project developed in collaboration with the people living in disability situations, and also which includes the videos and guidelines and online training and the experience sharing to show what is available to everybody on our portal. And also we held very good discussion with associations for disabled people who responded very quickly, saying they gave us a checklist. If you want this to work, have to do something which is kind of more amusing, something which inspires enthusiasm, and to leave simple messages. And so, practically speaking, they gave us 4 or 5 simple messages to be able to facilitate communication. That's what we did with them. And we arrived at the 5 following messages of what MSF can do, and training for all missions, and connect and get in contact. To give your projects in partnership with local organizations who represent the situation of people living with a disability. And so today we have the reflex to try to get closer to communities. It's a decision about patient-centered care to bring us closer to the community, and this message has to be more connected, as Louise has done, with local organizations for disabled people, and it's also a message which should be able to last over time. The second important message is to raise the awareness of our teams in inclusion. It's our attitude of other staff members, and it has a fundamental importance in our work to help change attitudes toward disabled people. And the third message is to examine the accessibility of our facilities. If somebody in a wheelchair is going to be able to have access to our buildings. And we have to use methods of audio and visual methods of communication that can be translated through sign language, and to make it accessible to everybody. And also recruit disabled people in our organization, because there's a direct link. If we have more people who are disabled working for us, we probably have much more sensitivity to their state and giving access to people to health care. So five simple messages to be able to help improve the situation of people with a disability. But as things stand today, we haven't got any overall visibility about all of the initiatives that are on inclusion in the movement. We have certain data, but we haven't got a systematic approach yet at MSF, and I think we have to be honest about that. There still remains a lot to be done. We already have some tools and a few examples of initiatives that are important to share. As we saw in this documentary, Louise wants to share who has done what, and to be able to reproduce the same thing elsewhere. And so Louise's project is fantastic because she opened up several centers in the project. In the project launched by Louise, Louise showed how we could work very closely with the disabled persons organizations. And these organizations, by definition, of whom the majority of the staff are people living with a disability. And so Louise, as we saw it, had trained educators among these organizations who then are in charge of sensitizing their networks of people living with a disability. And so the sign language and Braille as well. And so in this example is this work in collaboration, strong collaboration with local representatives representing people living with a handicap. To quote a few other examples that inspired me at MSF, another project which I found especially inspiring was the story of this team on a project working on sexual health and reproductive health in Zimbabwe. The team said in the beginning, We don't see in our facilities among the patients people who are disabled. We only saw women, and often they are also victims of sexual violence, but we don't see people who have a disability. So there's something which is not right. And so very quickly they said we have to do something to be able to attract these people. And so they did an outreach with people in situation of disability, and with organizations for these people working with the disabled to try to build a bridge. And so we also have to raise the awareness of our teams as well to work on the accessibility to their buildings. And so an approach which I found very interesting, which is a great source of inspiration, is the strong point is from the beginning of asking the question, there is something which is not working in this project. And it's one of the essential points which is an inspiration in relation to this project. Another project which also inspired me in my work, MSF project, in terms of accessibility, to give some different examples, the project of an MSF team working on the implementation of a reception center for families in refugee camps in Beirut. And from the very first day, the team made a choice of allowing accessibility for people with disabled people. And it wasn't easy because it was a big vertical building without an elevator. And so that proved difficult in terms of accessibility. So there was a lot of discussion between the medical team and the logistic team, but what can we do to improve the accessibility in this case? And so in discussing, they observed that what we can do, a ground floor which is very accessible, and on this ground floor, we're going to have a polyvalent room. So people who are disabled cannot go into the floor, into the upper floors, but the aid giver can descend to the reception area on the ground level to be able to work with them there. And so it was fairly innovative, and it shows that once we decide to make an effort, we can find solutions. And one of the final examples, this time in terms of communication with our patients, the example I'm going to give is one before MSF in the former Swaziland, Eswatini, that they were available in the project for tuberculosis. And the key for the aid givers was to learn sign language and to make sure that the patients, like their families, have access to this sign language as well. And so they created a partnership with the school for hard of hearing people, and therefore they had access to learning of the sign language, both for the patient and for the families. What's also interesting that the consequences of this was that the deaf people came to the health center after that. And so I gave you all these examples. In all these examples, I find these sources of inspiration for MSF to improve the quality of our inclusion and our care. And before concluding, another point I wanted to mention, I think it's important to keep in mind that our efforts for better inclusion of disabled person benefits in a broader way to all our patients, whether it's a matter of better physical accessibility to our facilities or have a broader sense of our projects, but also to be more aware of the barriers that our various patients face. So to wrap up, everyone's work to begin on our level, I wanted to make a little bit of publicity for our project. Look at the video, do training, and you're going to find enormous amount of ideas to be able to implement the inclusion by either working in an MSF office or in a project. You're going to find a lot of material, a lot of inspiration. And also with Louise, and don't hesitate to contact me or Louise if you want some information. And so, with the disability inclusion at MSF, I hope you forgive me for my self-publicity here. But thank you very much for your support. And so, Patrice, thank you very much. We're going to give the floor to Guillaume Le Gallet. then we will field your questions afterwards. Guillaume is the director of the visually handicapped in the Finistère, which is the west of France. They work with children and youth and adults with a goal of favoring inclusion. The association relies both on the expertise of professionals for the visually disabled, and also on the expertise of people who themselves have difficulty seeing, and they are able to say what is the motivation which has moved them to work on this topic. Elsewhere, MSF was the former operational director at MSF France between 2003 and 2008, and is presently the member of the board of directors. And so, Guillaume, the floor is yours. I'm going to repeat everything that Patrice has already mentioned. It's going to be difficult to not repeat things. But I was already interested in 2 points. How can MSF to get more interested in this idea of inclusion for the disabled? And the second part, this issue of accessibility, and where does that come from? The first point about the observation of the situation of disabled people, because there are moments in MSF's life, in the life of our projects, and in the life of operations, which ask particular attention, and we have to pay particular attention to these issues of disabled people. For example, the crisis situations in Ukraine today, for example, and when Benoit talked about Ituri, it's very similar to what we see going on in Ukraine today. That is, people who have a disability are often left behind. And they often are in difficulty faced with a situation which is almost the worst possible situation. And so we have to pay attention to that, in particular to these people, because these are people who are often dependent on a family level, and they're dependent in their daily living. And moreover, the second difficulty, independently of how society is organized, but how people living with a disability are institutionalized, and they live in specialist residences, for example, and for the care and to accompany people who are living in a situation of disability, or most likely like in the Congo, which often happens there. And so we have to pay particular attention to these institutions for the people who are living with a disability without any means to be able to live independently. We saw this in Kosovo when we arrived in Kosovo with Jean. The first thing we did was to carry out an analysis for people living with a disability, including the aid givers. And so the identification of the situation and our target public is also very important. What we also have to work on is in war situations, as soon as we're going to do surgery, with the people who discharge from hospitals don't often have 100% possession of their full capacities. And everything we're doing on the medical level is extremely important. But that doesn't prevent us, for the majority of people, when they leave the hospital, we hope that they're going to leave better than when they came in. But they're going to remain to a degree disabled. And so I think it's very important to be interested in the post-care work and how they can be better integrated into their own societies. Another moment in which we can study this question, MSF does a lot of deliveries of babies in hospitals, And sometimes the children are born with a disability, and which are preventable perhaps at birth. I think we have to get interested in how we can help the families with babies who are born with a disability in society to enable the parent to be able to take care of the disabled baby. But as soon as we get engaged in hospitals where with the care that are part of our responsibility, it seems to me that that's a field of work which I think we really have to study more closely. And the fourth aspect turns around the projects like we saw with Louise, that is medium and long-term projects. There we see also that our modus operandi and modus communication, they're not inclusive enough. And they are not just a natural part of our projects, in other words, not yet in any case. And so we have to give particular orientations for the cooperation with other facilities and other organizations to truly to help the people we want to reach. And there are certain points at particular moments where we could pay particular attention. The second point, we talk about accessibility. Patrice also talked about accessibility. What we have to understand is that we're talking globally in the world, including the United Nations. We are now in a rationale of integration. And also the approach of people. And there's a very important political moment, so that today, that goes hand in hand with this issue of disabilities, and we see it differently than we did before. It's an approach about the incapacity of people. Now we're working on a model which we call environmental and social. And it's the situation toward the disabled people. What that means is in the society and for everybody to make an effort and to do the processes that make us be able to make it so that services are offered to everybody. And over the past few years, we've seen with the patient-centered care that we are now moving toward. And in the world with disabled people, that it can change things a lot in the societies of many different countries, particularly where we work. So it seems to me that really have to deal with this, but for things to work, I think we have to make an effort. And as Patrice mentioned, this issue of accessibility, for example, I really want to insist a little bit on this. It's an issue of accessibility to the environment itself by our teams, and also where our teams can be able to receive people in our offices. And this enables us to roll out our activities much more easily. And so it's in our interest to work on that, and I don't know where we stand at the moment, but I think we have to continue working on it if we already are on it. But perhaps there are those in the room who might be able to clarify it for us. I think one single barrier is enough to prevent access. If you have somebody in a wheelchair on their own, and they have to go 600 meters in the hospital, or upstairs, or up ramps, for that person, that single barrier, it makes things impossible for access. We can't be 80% accessible. We have to be 100% accessible in all regards. So it is 100% accessible. This enables me to talk also about the accessibility. And it's something we can work on in our communications and in the tools that we use. But the issue of accessibility is vital because despite the progress we've been able to make so far, but regularly we find people, disabled people, in our hospitals with the total impossibility to be able to have access to our care. So I'm not going to go much further there on this issue of accessibility, but what we have to say, it's a matter of communication that was very well expressed in the film with the video and the needs of the people for communication. And what is essential is the primary factor for being able to increase inclusion. And so what can we do with our intentions at MSF around what we call patient-centered care? We see this thinking that we're doing on the beneficiary-centered care, and this goes hand in hand with getting close to the patients and to get closer to other associations for disabled people. It seems to me extremely important, who know the situation better than we do, and they could give us their advice about exactly how we could operate to be able to get closer to disabled people and to encourage them for care.
Je vais donner maintenant.
Thank you, Guillaume. And now I'll give the floor to Greg. Greg, he's going to speak in English. For those who need the interpretation into French, it is available. You can use a headset and get hold of your headset while I'm introducing Gregory. Gregory is a psychiatrist and is the focus point for mental health at MSF France. He's worked with vulnerable people in urban environment, homeless people, people who have disorders induced by the consumption of drugs and alcohol. And he's worked also with asylum seekers and refugees. He's worked in Iraq for MSF, in Jordan and Yemen and various countries. He's interested in mental health of young people, mothers, and that of refugees and other vulnerable people. You have the floor.
Thank you, Elba. I'm really glad to be with you all here today to share something that I'm passionate about, which is the fight for inclusion of people with disabilities and what we can do as an association and an operational entity to ensure that people with disabilities are actively considered and fully and meaningfully included in our strategy. And so in doing that, I'd like to share three things. So first of all, I just want to share with you my personal motivation, a story that illustrates that, and then move on to why I think as MSF we should fight for inclusion, and precisely where MSF's motivation for this comes from, what our charter says. And then at the end, asking how, echoing a lot of what we've already heard today from our colleagues and friends, how we could do that operationally as well. So for my motivation, I just want to share with you, ask you to picture a big refugee camp. A lot of you have worked in refugee camps. Some of you have lived in them as well. Masses of people packed together. You can imagine a place isolated, a big fence, rows of tents. And at the back of this camp, along the fence, after the tents, is a mattress. And on that mattress sits a man who is perhaps dustier than other people, who is perhaps a bit more disheveled than others, and who is rocking backwards and forwards and shouting. And if we had a closer look and we were able to speak with him, we might observe with him that he's suffering a great deal and he has a psychosocial disability. And this is someone who other residents have pushed to the edge of this camp. not because they wanted to, but because they really felt they had no other choice. And they've rejected him partly because of how he appears and his behaviour, and that's behaviour that they feel that they can't tolerate. And so this is a homeless man amongst the homeless, an invisible man amongst the invisible, and an excluded man amongst the excluded. And I wanted to think about that with disability as well, because it is about invisibility and exclusion. On a positive note, another example is what MSF is trying to put in place in Ukraine at the moment. And yes, of course, we have a need for surgical and medical care in general. But we've also asked ourselves, who's left behind? And who's excluded? And who's invisible? And in fact, it's a similar group of people who can't move due to physical disability, adults and children in institutions, and people with physical and psychosocial disabilities, and elderly people as well, people with dementia, for example. So as an organisation, I see us trying to respond to some of this invisibility and this need. I just move on to then what MSF's motivation is and where it comes from. And I think that comes from us asking how we interpret our charter. Many of us know that in 2008, the UN ratified the Convention on the Rights of People with Disabilities. And now it's the responsibility of governments and of UN bodies and various other organizations to enact that. The convention, it focuses on the individual rights of people with disabilities, and it takes principles of egalitarian liberalism, basically the rights of the individual, and it follows the Declaration of Human Rights, which we all know. But MSF is not a government nor a UN body. I do think that it's useful and important for us to examine our responsibility in our charter and our rationale, because it says nothing about individual rights or a right to health for that matter. But what our charter does say is that MSF's actions are first and foremost medical. We act under the principle, amongst other principles, of medical ethics. And we have given ourselves and we take a duty to provide care without causing harm, obviously, firstly, and also an obligation to ensure autonomy, confidentiality, consent, and that people are treated with dignity. And these aren't my words, these are MSF's words. And these are things that we do strive to improve and focus on with a shift to what we describe as person-centered care. And they're really relevant for this fight for inclusion as well. On the other hand, we also have a principle that we focus on impartiality. And we say in our charter that we strive to offer assistance to people based on need, irrespective of race, religion, gender, or political affiliation. And perhaps we should offer here or consider that as an organisation we can debate to add the phrase regardless of ability as well. And I'd be really interested to hear other people's perspectives on that. And I know that the association, through the work of Patrice and other people, Louise, is striving for this as well. Finally, operationally, how with our limited resource should we fight for inclusion of people with disabilities in our daily work? Because in the end, it's not about words, it's about actions. We can't help everyone, and we do need to triage based on needs. Often I think we triage based on what we did before, what we're used to doing. And again, I'm happy to see that change in the work that Louise is doing, the change that I see in Ukraine. Because when we choose to help some people, we also need to be aware that we're making a decision about not helping others. And who are those people? And it's okay to make a decision. We have to. We have limited resource and the principle of justice. We must make a decision, and it's tough. When making that decision, our main responsibility is to consider all the different needs that exist. And I'm so glad to hear today, adding that observation of the inclusion of people with a disability. In the world of mental health, there is a very strong there is a very strong movement of people with lived experience. And they have a phrase that they use, it's not mine, it's nothing about us without us. And I think that's a helpful phrase to think about. That when we not just deliver our care, but when we establish and imagine our care and design it, our strategy, that we include people with lived experience of disability in the conceptualization of what we do. And it's easier said than done. And I would also ask us to think about what we as an organization look like. Are we an organization that recruits and really considers disability in the way that we structure ourselves? Do we recruit, do we support people with disabilities to do the work that they need to do? And are we an organization that looks like the people that we care for? So I just want to end on that and just thank you all.
Merci.
Thank you. So you've had the opportunity to listen to our three speakers, and now we'll move on to the debate. Louise is also online with us, and you'll have the opportunity to ask her question. There is a second microphone. I will need somebody to help me give the microphone to those who would like to take the floor and ask a question. So please don't hesitate. Maybe I can start. MSF does a certain number of things, but MSF hasn't done a lot over the recent years. Maybe that's a question that I can ask Louise. Louise, why do you think we have done so little? Isn't there a kind of social despise? Is it because we only have a utilitarian approach? We want to save the higher number of people, and that those people who are with disabilities do not represent the highest number of people? And I'm asking you the question, how is it that we've done so little so far? Thank you. Can you hear me? Yes, we can hear you, yes. Well, I think that we are late. Because I remember I attended the International General Assembly when we voted this motion in 2016. And we would say that this motion would be enforced. But the problem is that enforcing such a motion takes time, and it has been delayed. And also at MSF, and that's my personal analysis, we want to provide care to everyone, and it takes us away from actually considering people with disabilities, because we think we provide care to everybody, but that's not the case. This project has shown that we provide care, but that there's a category of people that we cannot reach out in our even though we have a policy or a strategy for health, we have not identified the fact that some people were not actually included in our health policy, and we've missed those people. That's something we've seen in the film, in the video. So it's up to us to really keep track of this problem, monitor the problem. And fortunately, we've worked with people with disabilities, and we've found out a problem. While we thought that we were actually providing care to those people, but we're not reaching out those people. In the video, we could see these deaf or hearingly impaired people. And you've seen an example of the workshop. The question that we constantly ask ourselves is, do we actually reach out those patients? There is no sign language interpreter, for instance. We've seen that in this video. There's this woman who says that I was there with my mother for the consultation, and her mother, who was acting as an interpreter, said that her daughter was 4 months pregnant, while the daughter said, no, I'm not 4 months pregnant, I'm 3 months pregnant. So MSF should make additional efforts and try and see what could be done in the forthcoming years to actually tackle this issue of inclusion and make it a priority, even though there are other concerns for us, but it's also a medical humanitarian concern. If somebody doesn't have, a woman who doesn't have any information about her pregnancy, then she's exposed to a high risk. Louise, for those who are watching online, you can also ask questions by using the chat function on the website of the crash. Anybody would like to ask a question here? And please introduce yourself. Annelise Granier is my name. Thank you, Benoit, and thank you, Patrice and Louise, for this film. I'm an anthropologist specialized in Africa, and I've worked for many years in Mali and Burkina Faso. And I've worked more particularly on access to healthcare for people with disabilities, and more particularly people with a hearing impairment. So this film means a lot to me. I have found in this video many things that are common to a film that we have made a few years back. But the actual question when it comes to deaf people is the importance of peer education, because you've talked about how important it was to have interpreters, but there's the issue of language. You're talking about French-speaking countries, but also in West Africa or other countries, the learning of sign language is done with the American Sign Language. It's called it's French Sign Language with local sign language plus American Sign Language. Now, if the information is not conveyed in a language that is commonly understood by everybody, it will be only accessible to those who go to school. Sometimes the message may be conveyed in a written form, but if people are illiterate, it doesn't work. Now, if the person cannot have access to an understandable language conveyed by a peer, I will give you an example of something that I've observed in Burkina Faso in an awareness raising campaign. A deaf person is is a chatting box. And when there's an awareness-raising campaign, it's provided in sign language, as it is taught at school. But a few signs are recognized by the people, but they do not understand the link between AIDS, HIV, condom, fever, etc. But the link between all these items is not understood. I have carried out many interviews, and people said, well, I used to have AIDS, but now that I've started working, I don't have AIDS anymore. And what is your job? I'm a construction builder. The person was working under the sunlight and thought that he didn't have AIDS anymore. Same with a pregnant woman. She said, I had AIDS when the baby was born. Then I didn't have AIDS anymore. And more than that, and it was shown in our video, in our film, a woman said, well, I've understood that in order to protect yourself, you need 3 condoms. 1 is not good enough. That's an example. Another one said, I've understood my husband has sexual intercourse with many other women, and he wanted to use the condoms, and I didn't want him to use the condoms because condom is the source of AIDS. She had made a link between AIDS, HIV, and the condom, and she thought that the condom was the vector of the disease. So there are many such examples, and I think it really is an issue, and in Burkina Faso. So the question is, it's mainly a contribution to talk about peer education. It is indeed very important to focus on peers, because otherwise it's very complicated and it doesn't work. You can't convey the message. But I have a question to Louise regarding the deaf people in DRC begging. Not begging as the one we see here in the street, because there are networks of beggars and sex workers who are exploited. Is it also who are deaf, and is it also commonly observed in DRC? Because it is also a way to transmit AIDS even more so. Louise, we can't hear you. The microphone is not on. Well, the DRC is a poor country. So it is also true for its people. And for people with disabilities, it's even worse than that. They're the poorest of the poorest. Quite often they live out of begging. And in the field, we could ask all the possible questions to those people, and they were unable to fend for themselves. Some of them had been rejected by their families because they are a burden to their families. They couldn't go to school, and they couldn't be supported in their everyday life, and they end up in the streets. And then it's very complicated because they can't talk. They walk out in the street with a child who will be begging money for this person. This poverty also drives them into prostitution, but they're not visible. They need to find a way to make a living because there's nobody to help them, be it the official support from the government or local NGOs. Another problem is that even though deaf people might have had access to higher education, they do not have access to the labor market. So they will try and survive by any means. So they are exposed to high risk. They live by the day, and they have to make ends meet for their family. I'd like to add something about Louise's program, which was not in the video, which is a 26-minute, which was only focusing on inclusion and transmission of information. But what is quite admirable in Louise's video is the economic factor. When you deal with these people, you are faced with their plight, and you cannot ignore this first hurdle, because even before accessing these awareness-raising workshops, they need to have access to food and income. So Louise has worked with various associations to identify the needs of those people, logistics, refurbishment of buildings, access to other items such as braille writing systems. And so she's relied on a whole network to alleviate those people from these economic needs and improve their access to healthcare. And when we talk about inclusion, of course, this will open up more debates on what is it that we can do from the social and economic standpoint for those people. Thank you, Benoit. Anybody in the room would like to ask a question, or do we have questions on the chat online? I see somebody in the back. My name is Laura. I work at the operations department at OCP. My question goes to Louise. You've shared this pilot project. Was it presented to other organizations in this section? Did it have a snowball effect on others? And was this project analyzed and assessed? Have patients drawn any benefit or any lessons from this project? Okay, my microphone is on. Okay. I think that we've shared this project with several organizations. Oslo was the relay for other NGOs, other MSF sections internally and also outside MSF. But it's not only about MSF. We've worked in partnership with other organizations, with some NGOs that have supported us with some material and equipment. I'm thinking about the condoms and everything. We didn't have that in our project. And we've worked with other organizations to further support this effort. And we've shared this with other sections that are present in DRC. When it comes to the evaluation of this project, initially, we did an evaluation with focus groups to try and understand the needs of these communities. And we found 11 associations of people with disabilities. We started to work with them. And we selected 10 people living with disabilities of these associations to work with us. And they were very happy of this cooperation, of this joint work, and of the involvement of MSF, the effort of MSF to reach out those people, because they said it's the very first time we are involved and that we are working with an NGO. This project is about to end, but there is another organization locally in Africa called WACA, for Western Africa Center, that is going to take hold of this project. And it means that it is a success for us, because quite often in the field we were asked, then what's going to happen after the COVID pandemic? Are you going to abandon us while we are focusing on HIV and family planning? And they said, well, what about the future? What's going to be done after we've completed this project? And we've discussed with WACA, and they said they would agree on taking on board this project. So we shared it with other organizations. We shared it internally with MSF. And today we are very happy because another organization is going to take this project over. Thank you, Michael. Make sure that he gets the microphone.
So good evening, Michael. I work with the Crash. I have a question which is addressed to Patrice and Guillaume, especially in the job that you occupy at the moment, which concerns the change. Patrice, you spoke about the effect of neighbors in your analogy. And so we have about 70 projects at MSF, and so that means a lot of resume. And so I want to ask the question of the limits of this analogy, and that's why I would respond to Guillaume's experience. How in an institution like MSF or several organizations, how we can provide a change beyond the processes by analogy, via template. And how can an operations department be normative by saying that's enough and we're going to work in this sense? We've already done this for treating victims of sexual violence with people who are experts in it and whose job it was to try to orientate and weigh on the orientations of the projects. And we're doing it with the patient-centered philosophy now. Can we do without being the leaders, to be able to, in the name of the directors and the association, and also that count with the bodies in our organization. And so, Patrice, but I can try to answer. Guillaume may have more elements than me, but the strategy included a lot of what we could call advocacy internally, as to inform and present the project, what it's possible to do, and to have a whole set of recommendations and of training and material that we can present, and videos for the awareness raising, and to be able to promote them in the movement by saying that this is to demonstrate that it can be done. So let's go. And so there was a lot of internal advocacy and communication with the trainers as well. And so our strategy was based on communication internally, and there, and effectively, where I can give the floor to Guillaume, it's up to the decision makers and to implement. And so we, as advisors, we can make recommendations and to say, this is what we have to do, and we even have tools to be able to do it, so let's go. And so we can also influence, but we can't direct. And after that arrives on the table of the decision makers, and they may take different directions within the movement to decide to implement. And we can see in the movement very highly varied reactions, usually very positive, but then occasionally proactive. I saw in Athens and Barcelona, they were very positive about that, and they're very strong to answer Guillaume's question, to develop guidelines on accessibility for the medical solutions. So a little more advertising for us. They have a website with the guidelines in medical facilities and developed in 4 languages, Spanish, Arabic, English, and French. And they're very good guidelines. Don't hesitate to consult them. And so that's just an example where we were very reactive on that. Brussels is also very good with a platform for AIDS promotion, health promotion, during the COVID period. And the COVID was a real boost for inclusion in the sense that the disabled people could consult these websites. Each operational center is going to have different reactions in the way they react. And for us, it was learning and development that we put the accent on, which was very sensitive to training and learning. There. And now it's a part of international training with the younger generations. And so we received varied responses according to the operational center, and they provided the services very different. We realized at the end of the day that the health promoters in the in the operational centers influence other directors in other operational centers, and that can lead to an influence. And after that, there's a whole project for deciders to push more for implementation. And this is where I'll give the word to Guillaume to be able to extend a little bit of what I'm saying. It's hard to answer this. I think it's complicated in the conversation because, in fact, it's a deep culture within MSF. It's not something you could change from one day to the next. And in my opinion, to take care of pain, abortion, and also the compassion centers, this takes years to implement. The reality is it's much more complicated than just changing the protocol for health promotion. That is part of the efforts that are particularly important, that has to be done and supported. And this also lets me respond to Elba's question that she talked about at MSF, with the blockages are at MSF. The issue of disabled people, at least in France, it's even a very common experience here in France itself. If we examine more precisely, we see there's a lack of members of the board who was hospitalized in Brest, very near me, and so we saw the possibility. It's a succession of disasters. There's nothing been done for the patients, particularly disabled patients. If they're a little bit ill, and they find it easy to arrive at the health facilities, and the patient circuit is completely faulty, and those remain today, and it's absolutely actual today, and I think we have to support that over a long period of time. And one of the reasons that we think that it's more complicated with us is that, without insulting anybody, I think the medical corps reacts poorly with this issue of disability. We have to try and find a solution to a problem in medical terms, usually. And there, the difficulty with MSF, where we lack things, they're not going to do a proper care. And I see regularly with disabled patients who we often get feedback. How did things go at the hospital? And how did it go? They said it was just a disaster because at the hospital they told her that there's nothing we could do for you. So just get by as best you can. It happens in France even. Because that confronts people with something that is which they are diminished to be able to propose solutions. So there's a real difficulty, in my sense, in my opinion, and concerning our approach to this issue of disability. Another example, in the hospital world in France today, there are very few ophthalmologists who are concerned by the issue for people who are blind. And we see this throughout the French nation. Because this is a level of failure that, in fact, we can't even handle very well in France. But it's going to take some time, And we're not going to find solutions from one day to the next. And that has to be a part and integrated into our policies. And I think that has to be a part of the operational policy. And the directors have to get interested in it as well to be able to set up projects which address most particularly this population. I think what Fabrice, for example, is doing, I think it's very good to be able to address that. But I think we have to talk about this history, this story. Has to be particular attention has to be paid to this. So, any other questions from the room or in the chat? If there are people online who want to ask a question, enter it in the chat. So, Michael, I work in the operations. I have a question. The way of making visible the question of donc we have statistics, but it's our way of making visible the topic and the theme, and also to better help people. So I have a question for Louise, I think. That is through the community activities and the organizations that work on a daily basis with the local people who are affected by this handicap. In your activity for MSF in Kinshasa and the statistical data of the beneficiaries or the people who are trained, who are affected by a disease like HIV, has this led in the data gathering or in the HIV program in the Congo? So are disabled people, are they made more visible by your activities? The key populations that we want to reach. The sex workers, for example, to make individuals through the categories of people. And I wonder if it's not perhaps a good way to make these people more visible. I don't know in the Congo if that can evolve at all. I'll take advantage to ask the same question to Greg. In the medical department, do you have any data in mental health as a disability? In Kinshasa, I worked in health facilities, and I was a part of the General Secretariat, and I asked for information to the minister just to learn that there are no real statistics in relation to disabled people. Even on the medical level and the accessibility level, there really are no statistics in the database, whether it's in the government or also on the level of facilities or the Ministry of Health. But with the 13% of the population disabled in the DRC, it was done under Mobutu, but to date there is no analysis by the ministry or the government to try to identify real statistics about accessibility to care for disabled people. On the other hand, when we built the project, we said that our objective, we have to try and reach at least 2,500 people living with a disability. Now, concerning HIV, we even reach more than that because by the lodging situation, everybody was interested, in all disabled people who were not part of the association were interested to be informed about HIV and family planning. And concerning the family planning, we raised the awareness with more than 2,000 people. But among them, there were also positive cases And these positive cases were referred to the HIV center, a hospital center in Kapinga, and also the project in Kinshasa, and they were treated in various facilities to try and cure them. And so to have statistics on the countrywide level, or at least with the Ministry of Health or other NGOs, or with the organizations, but they haven't got any statistics. They've said that to date we haven't made proper analysis, and there's no way to identify anything on the medical level or accessibility or the programs for disabled people. No strategy, no health strategy to identify, to have an analyses of the in our databases in the DRC. So I'll give the floor to Greg.
Look, I think the point that you made that we in order to do this better, we need to measure better as well. We need to describe what we do in numbers and qualitatively as well. I think when we're collecting data on action with people with lived experience of disability, including psychosocial disability, and people with other vulnerabilities, we also need to be aware of sometimes the risk that can put people into. In some places, certain identifications can put people at risk, so we need to, I guess, work with people with lived experience to make sure that they're happy with that description as well. I can't speak for other sections on how they describe their work with people with lived experience. I think we try to do that here in OCP, in MSF France. It's been more qualitative so far.
Ok, thanks. Quelqu'un d'autre a une question? Oui, je vois une question donc à gauche.
So any other questions? Somebody on my left? Can we get a mic to them? I'm a student in economic development, but I have a question for Guillaume. He spoke about we went from a rationale of integration to one of inclusion. I don't really quite understand the shade between the two. What's the difference between integration and inclusion? And so can you talk about the two models, more medical, technical versus the social model? And I am wondering if you wouldn't mind coming back to the project in Amman. Can we articulate these two dimensions? Is it just passage from one to the other? But I don't know the whole story. But for the deaf, it was called the Institute for the Integration of Deaf People. And it was set up about 10 years ago. And it's become kind of stylish to talk about the situation living with a disability. When we debate about the changing the name, it was complicated. That complicated the discussion, even though it was very interesting, because a certain number of people were for changing what we call inclusion rather than integration. And so, effectively, the society has evolved in its attitude and will have understood the need for being more precise in our language. And so there was this sort of desire to get to that point, but certain other people in the debate thought that was all well and fine. But in the end, it's always extremely complicated to include the disabled people in a given space. A child who goes to school, a normal school, has to be properly equipped to be able to receive them. and it requires an enormous amount of effort. And even if the environment is totally adapted, we don't really know correctly this notion of inclusion, all the efforts that the disabled person has to do to be able to share the space with what we call so-called normal people, and the work for everybody. There are a lot of examples like that, and with the disabled people, we made some certain offers, but the issue of integration, it was for the people to make the effort and to be able to integrate into the society. And we knew that society wasn't accessible. But today we imagine that tomorrow's society, so we talk more about inclusion today, to enable people to be able to be included in the society. For this issue of fathers, for example, as we mentioned before, to overcome incapacities, we have to be able to measure the condition of the disabled person. This person isn't able to go to the toilet on their own, and you are handicapped, for example, to what degree? And we have the people of disabled people in France, and depending, you're going to have the proper resources to be able to respond to their needs. And so there might be 30, 40, 50 different cases and levels of disability. And so it remains interesting. It's very clear that when you're blind, that means a certain number of things. This disability of not being able to see, like the disability of being deaf. But the issue of the social model or environmental model, that's where we have to enter into the debate with disabled people themselves. For example, what they're asking for is to be able to have the same benefits as everybody. And that's why the word inclusion is used as opposed to integration. And to be able to adapt to the environment is very important. That's why we use the word inclusion. And at present, we are still in a different frame of mind, because we talk a lot about self-determination with associations which are more and more activist, are closest to us more politically, to be able to express their needs and to be able to contest things they don't like. And so they contest the right of what we call valid people, and they go into society to listen to other angles to this issue of inclusion. I don't know if I answered your question or not, but give me specifics if I haven't. Are there any other questions in the room? And so there's a question in the chat, and she's going to read it to us. I have two questions in the chat. The first is from James, who wants to talk about the financials of it. Does MSF have the funds to improve accessibility financially to all its medical facilities? And the second question comes from Vina, and for Gregory. You mentioned the disabled people in the response to Ukraine. Can you give greater detail about this topic? So concerning funding, perhaps Patrice could respond. So from a financial point of view, these are arguments which are put forth sometimes to do nothing. But in fact, we can do an enormous amount of things that don't cost very much. I'll give you a very simple example, which is linked to the Ukraine. The emergency interventions, for example, for the moment when a crisis arrives, it's not perhaps the best moment to talk about inclusion in relation to our operations. On the other hand, what's important is that there has to be e-prep before. And we have to be active in the preparation to possible emergencies. And there's a lot of work that has to be done to prepare the communities to disasters that might arrive. And there are more and more people living with a disability. So the work of inclusion consists in organizing, inviting disabled people to the meetings like other people. And that leads to a variety of different people who are included in our consultations, and that doesn't cost anything. And so the inclusion in other organizations for disabled people, it really doesn't imply a lot of cost. But it's just consulting these people and to go out to see them and to be able to treat people in a situation of disability. It doesn't go that. This also enlarges the field of the possibilities of our activities. We're going to recruit people who are going to have a value added to the projects, because you have with sign language, for example, because they have experience with disabilities and discrimination, and it doesn't cost anything. But if we think about the issue of funds, we talk about reconstruction of our facilities, which agree with other organizations that work on building. One thing which is very important, sometimes we rehabilitate and we rebuild after a natural disaster, for example, and but if we're going to rebuild, then we have to do it with the accessibility in mind. That, from the beginning of the building. And so if we're going to redo buildings, then we have to take into consideration accessibility to that building. And that's more or less in the design of these buildings, which we have to take that into consideration. We have to take reconstruction, we take it as an opportunity. If we have to go into a new structure, we have to be able to work in a more accessible way. And the cost is very limited for that. It's just part of the conception of the building. It amounts to about 1 to 3% of the conceptual phase of a new building. And so the overall cost, like Louise's project, these are projects which don't cost very much, which use very small envelopes of funds from the association for support from the associative. And so the financial argument in relation to the fact of including populations which are the most denigrated, from my point of view, that they really don't hold up. Because the role of MSF as a humanitarian organization is to include the most deprived populations, and it requires very little funding, in fact, to do that. I don't think it's really a very good argument, at least in my opinion. And so I'll give you the microphone for the question posed by Jean-Luc.
Medical operational experts has just returned from the Ukraine, and I wonder, Natalie, if you could describe.
Okay, I'll continue in English because Greg started in English. So yeah, I think what Greg was... Oh, sorry, I'm Natalie. I work at the crash, and I've just been in Ukraine for the last 4 weeks. I came back at the weekend. So yeah, I think what Greg described was quite accurate. I think we realized relatively quickly that the people, the biggest victims for us of the war is not necessarily the wounded. Obviously, there are some wounded. But there were the people who were stuck because of their age, or because of their disability, or because of just essentially that lack of mobility, or because they had other reasons to be sort of stuck in certain areas and certain situations. So the most striking one is the people who are living in the zones west of Kiev. The areas that were occupied and have now just been retaken by the Ukrainians, where we found that actually the people who'd managed to leave were the younger people, the people who were able to get in their cars and drive away, and the people left behind were actually the elderly, the people who were stuck at home, they couldn't leave their homes, or they were stuck in institutions, which meant they were just unable to get out and to evacuate in time. And so in terms of our operations, what's happening today is we're now able to access those areas, and what we're finding is a group of people who were already sort of chronically unwell, had issues medically often, or psychiatric disorders, or even just alcoholics who in Ukraine can no longer drink because alcohol was banned in Ukraine from the beginning of the war. And so we found a sort of a population who were already in a poor state or a difficult situation, who have now completely decompensated due to the circumstances of the situation, living through a very, very violent experience, They couldn't leave even if they were able to leave their houses because they risked being shot at. And so therefore they were stuck at home, no electricity, no water, no access to healthcare. So that's the most extreme circumstance of these people who are left behind, and our operations to try and now provide medical assistance to them, but also social assistance to them. Even if we can manage to get them medically back to a better state, they're probably not going to be able to live at home on their own anymore, so we have to start thinking about the future for those people and where they can go. But there were other people who didn't find themselves behind the front lines, but also in a similar situation where they were just unable to flee, and found themselves in a scenario where they were unable to access medical care as they used to be able to, partly because the entire medical system in Ukraine was reoriented towards the wounded. So hospitals were a bit like the beginning of the COVID pandemic, were told to only accept wounded patients, which meant that people, even if they were living in a more stable area, had found it much more difficult to access healthcare. The population that fled in some of these environments were the young, the fit, so they also found themselves deprived of social contact. Maybe they were housebound, but they used to have neighbors. They no longer have neighbors visiting them. The social workers who used to visit them are unable to get to them because they don't have fuel. So all these different problems that meant that people have found it more and more difficult to access their normal social and medical assistance that they're dependent on, and particularly those people in institutions. And in Ukraine, there's quite large institutions for people with handicaps or people with psychiatric illnesses, and they've extremely suffered in this context. Operationally, what we've been trying to do is work out how best to support the Ukrainians that are still working in those institutions or working in those environments, so the social work teams and the staff working in the institutions. And today we had a discussion about some of these people living in areas that are not yet on the front lines, but we think could end up being on the front lines quite soon, so particularly in the east of the country. And we had a discussion with the government of Ukraine today about whether we can support them to evacuate some of those people from the very, very dangerous areas, very unstable areas, to institutions or safe accommodation in a safer part of the country. So it's a first discussion we're having about how MSF can collaborate together with the Ukrainian government to provide those sorts of services. It was interesting having those discussions on the ground, because I think a lot of the MSF teams hadn't really thought, they thought it's an emergency, it's a war, therefore we're there to manage the wounded, and probably we're there to manage the IDPs or the refugees. But actually what we found on the ground was less that and more the people who seemed most at risk and most kind of suffering from this war was this entire population that tended to be sort of excluded anyway from care and often hidden away in institutions, and are now sort of, in a much worse state than they were before. So it's difficult to understand how best to help, but it's kind of the orientation of our programs right now, and OCP is heading in that direction.
Thank you, Natalie. And I just add very quickly to, I fully agree with all of those points. And people with dementia are also people with a psychosocial disability. So I know that we're considering ways to support those people practically, working with partners. And so, yeah, I guess taking that broader view of disability, including psychosocial, including people with dementia, intellectual disability, in the consideration as well.
Merci. On a peut-être le temps d'une dernière question.
Well, maybe there's time for one very last question. No? No further questions? Okay, then we'll stop here. I'll briefly conclude and explain that when I was asked, why is the crash organizing the debate? And I said, well, why not? Maybe this answer was not well grounded. Well, maybe it's because it's a blind spot at MSF. It's something that is not so visible, because it's something that is difficult to deal with politically, internally, because everybody is in favor of inclusion, of course. But then you have a few people who are feeling that they're truly concerned by this topic. And also because it's an operational issue, and today it seems that all the speakers have shown that it is an operational matter. at all levels. Now, before going for a drink, I would like to thank Point du Jour, the production company for the film. I'd like to thank Benoit and Louise for the film. I also would like to thank all the participants, all the speakers. I also would like to thank more particularly Joël and the whole technical team for the whole technical assistance, because it was quite a feat today to have this event organized here in the atrium with all the cameras and everything. I also would like to thank our interpreters, Agnès and team, and Maud and Sonia for the sign language interpretation. Thank you. And eventually, I'd like to thank Madhulika, who's been working with me at the communication department at the crash, and she's been a great help. Thank you. Thank you to all of you. And let's go for a drink.